Hi, Dharnika.
Hello, ma'am. Good evening, ma'am.
Good evening. So give me 5 minutes, sir. Will join and we'll start the class. Okay?
Okay, ma'am.
Okay, then.
Hi, am I audible?
Hi, sir. Good evening.
Good evening, good evening.
Sir, I have make you the co-host, sir. You can share the screen and start the class, sir.
Sure. Right. Okay. Okay. Shall I start?
Yes, sir.
Okay. So, hi everyone, and welcome to this 90 days foundational life class. I'm Dr. Ankit, your faculty of anatomy, and today we're going to start on a on a new topic, and that topic is our upper limb, right? So today we are going to start on the upper limb topic. That is also which we used to call it as also supex or superior extremity. We used to call it as supex or superior extremity. Okay, so any part of the body in gross anatomy, particularly when we start. So till now we have finished embryology genetics, and now we are coming into the gross anatomy. So whenever we start a gross anatomy, whichever part we take, supposedly superior extremity, we start with the osteology of it. Osteology, that is the bony part. Okay, so and osteology, normally in upper and lower limbs, we go from proximal to distal, meaning by proximal is this area of the upper limb around the shoulder region, and distal are your hands and the fingers. These are the distal area. So in osteology also, or in gross anatomy also, when we will study the all the soft tissue, the muscles and the vessels over here, we go from proximal to distal. Therefore in osteology, we are going with the bones like clavicle, scapula, and humerus. Now all of these three bones are one of the most common bones asked in your vivas. Take your part leaving viva, or take your main prof viva, or any viva in the upper in anatomy, or you can also say later on in the other subjects, like you can even ask you points like in orthopedics and all. But yeah, these are one of the most common bones that are being asked. So this is what we are going to discuss today. So welcome all. We'll this session is going to help in your prof exams for sure, and I will give you in between various important tips and tricks to for you to solve the MCQ exams as MCQ questions in your next or NEET PG exams also. Okay, this was a framework. These are the sort of questions you can expect from it, and you can take a screenshot of it, right? The long essay, or short answer. And do remember, there's the whole Viva VOC question, which is based on this only. And osteology Viva, bone Viva comprises a large percentage, a large chunk of your total practical marks. So there's osteology Viva, then there is a soft tissue Viva, where the dissected specimens are kept, right? And yeah, they constitute a large percentage, a large chunk of your entire whole viva voce of the anatomy practical. Other things also there, like embryology viva is also there, histology viva is also there. Then you have surface marking is also there. But the soft and the hard part, this osteology comes under the hard part, obviously, right? So it comes under the hard part viva. And yeah, for viva voce also it is a must. Okay, so I choose Oracle, and I'm sure by now you all of you must have downloaded the app. There are a lot of good features in the app, as you can see on the screen. We have every sort of classes. We have practical sessions also. We have hard books, hard copy or hard notes book set as well. These are all the different features which you get on Oracle. Beautifully crafted notes also. In the app, we have features like latest medical news and all. These are the different plans which are going on. You can choose from the foundation plan, that is for from 3 months, to ultimate MBBS plan that is complete for 4 years. Okay. And there's a different price strategy, and obviously you can use the code below written as Dr.Ankit 2% discounts. Right. Let's come to the topic. And today, as we are going with this osteology, and therefore I would like to show you over here that we have the bones also, as you can see over in the screen in the upper right corner. We have bones like the bones that we are going to discuss today. This is the clavicle over here. We have the scapula bone also over here, and we have the third bone, that is the humerus, also over here, right? So we have these bones which we are going to discuss today. Okay. Fair enough. So let's move to the note side, and simultaneously I will tell you about the bones also over here that we are going to discuss. Just a second. Let me shift it a bit over here and increase the right. So yeah, we are going to start with the clavicle. We are going to start with clavicle, and then we'll come to the scapula and the humerus. So first things first about the clavicle. Let me take an empty space over here, right, and tell you some important things, must know things about the clavicle, which every medical student should be aware of. Okay, the bone clavicle over here. So first of all, clavicle. Few important points I'm going to write over here. This is the bone clavicle. Okay, it is situated like this over here. Let me try to show you. It is like this is the right side clavicle, and in osteology, in the vivas also, first thing is there are two, three set questions, set pattern of questions are there. Two, three set pattern of questions. Once you reach the viva table, obviously you will be greeted or you will greet the examiner, and then they'll ask you what you have learned or not. Then they might give you this bone, or they may ask you to pick up any bone, and you'll pick up the bone. First question that comes after all of this initial greetings is, what is the name of this bone? Okay, so this one I guess is easily identified with this S-shaped curve. Also, you can see the S-shaped curve. This is the clavicle. It is situated over here, so also known as the collar bone. The second question which the examiner frequently or normally asks is that, okay, it is clavicle, right? Which side which side it is? Is it of the right side or is it of the left side? So that's normally the second set of question that is asked. Then you have to tell the side, okay, and while telling the side, suppose this is of right side, which it is, you will have to hold it in your right hand. Okay, you can't be holding in the left hand and saying, oh sir, it looks like of right side. And the answer is not wrong, but it doesn't look right, no, so it doesn't look correct. So best way is, if it is of the right side, which it is, then you have to hold it in the right hand. If it was of the left sided, then you should have hold it in your left hand. Simple sense of logic over here. Then third question which will come is, okay, you have told the side, fine. Why do you think it is of the right side? That's normally third question. Then you will say, okay, sir, it has this medial part or medial end is quadrangular, lateral looks like this. Middle part is anteriorly convex, or the middle two-third of the middle half of the shaft is anteriorly convex. Okay, if you're telling this much only, then the examiner might say, okay, now try to put it on the left side. Again, the middle part anteriorly is convex. Then it is a hint that, okay, give me a complete answer. Because if you only said this 2-3 points, the answer is incomplete. Then you will say, okay, so it has a conoid tubercle on the inferior surface. Okay, it has subclavian groove over here, features like this. This justifies that it is of the right side. So this is sort of set pattern of questions that are asked in Viva OC. Then other points will come. Okay, name some bone, name some muscle attachments, and what does this bone do? What passes through it, and blah blah blah. There's the questions. Name any applied part. There's a fracture of it. How does a fracture happens? What is the mode of injury? And so as you progress in your Viva, the more correct answers you give, obviously the examiner is happy from inside. Okay, the student is giving correct answers, and more in-depth questions will start to come. Okay, that's what happens in your Viva OC, and clavicle is one of the most commonly bones that is asked in your Viva OC. When we were in UG, when we were in first year MBBS, this clavicle was famously called as a 6 month bone or supplementary bone. Then we asked her why such a different name. Then our seniors told that it is such a easy bone to learn and study that even if you are not able to answer this bone, then the examiner thinks that, okay, the student needs 6 more months or for to clear the course and all, because if you are not able to answer this one, then it is expected that your knowledge of anatomy is not on a not at a level at which you should be passed. So it was known as 6 month bone or a supplement. Fair enough. Uh, let's come to the topic. So a clavicle, few features you should know about clavicle, that it is the only long bone. What it is the only long bone which is lying horizontally. Which is lying where? Which is lying horizontally like this, not vertically. All the other long bones in the body, be it your radius, ulna, humerus, femur, all that, they normally are vertically, but it lies horizontally. Okay, it is one of the initial bones to ossify, and basically its ossification is a bit different from majority of the bones, because majority of the bones they have a endochondral ossification. This in this clavicle we normally have a membranous ossification. Membranous ossification. Do remember this also. Okay, clavicle lies horizontally, and it has a membranous ossification. There are many other things that it has two primary central ossifications. So that is all. But yeah, you should know this. Do remember about the bone that it has a sinus curve, as I even showed you in the image. We can look at the bone over here. Can you look this? It is not straight horizontal. It has a sinus curve. It has a sinus curve over here. I hope you can see it, right? So when it has a sinus curve like this, the sinus curve like this, and it is a bone also which can be easily be palpated. It is subcutaneous actually. It is just beneath the skin, so there is no very thick muscles which are covering it all around. So you can simply feel it. Okay, this is a collarbone. Clavicle is also known as the collarbone. Also known as the collarbone. You can actually feel it. When you can actually feel it, then try to feel it. When you are feeling this bone, as we are touching it on the medial side, towards the sternum, medial side, you should be feeling that it is more projecting forward. And as you are going laterally towards the shoulder, when you feel its sinus curve and you see, okay, there's a indentation or the bone goes a bit inside the body. So it means that this bone medially it is more projecting forward, or it is more convex anteriorly. Okay. So as you see on the me, so let me put it into words over here. The medial part of the bone, the medial part of the shaft, or we can say, is more convex anteriorly or more projecting anteriorly. Convex anteriorly means, suppose I make like it like this over here. This is a bone over here. Okay. And suppose this is the medial side, that is the lateral side. This is anterior, that is posterior. Okay, so this is the right side and it is more projecting anteriorly. So middle part of the shaft is anterior, it is convex. And therefore, simultaneously, lateral part of the shaft, okay, it is, what is the opposite of convex? It is concave. So it is anteriorly concave. It is anteriorly concave. Okay, medial and lateral part. That even you can feel it. I mean, you can touch it and you can understand. Okay, so obviously, what are the parts now? Again, comes your basic anatomy. The parts of long bone. Long bone has two ends, so it also has two ends, one medial end and one lateral end, and it has a shaft in between. It has a shaft in between, some simple as that. So obviously, it has a medial lateral end and a shaft in between. This is a basic, just to begin with. Now, can I identify the bone? Simple. Now, why it is of right side, as I told already, that okay, the medial part of the shaft, this medial part of the shaft, as you can see over here, this medial part of the shaft over here, it is projecting more anteriorly, and the lateral part of the shaft, it is going a bit back. Apart from this, once you get hold of this bone, on the lateral part, now how to identify lateral part? The lateral end is a bit flattened. The lateral end over here is a bit flattened over here. And if you compare it with the medial end over here, the medial end is rounded. As you can see over here, let me bring it close. Yeah, this is fine. This is the medial end of the clavicle over here. I hope you can see this. I'm bringing it close to the camera. It is attached to sternum. So this will form which joint? A sternoclavicular joint. Now, I hope this image is fresh in your mind. Now look at the opposite end. This is the opposite end. You can see how flat it is. So easily the two ends can be differentiated. This actually articulates with the acromion process of the scapula. So this lateral end over here, it forms the acromioclavicular joint. So this is the sternoclavicular joint. This is the sternoclavicular, and this is the lateral part. So it will form the acromioclavicular joint. This point is clear. So now, as you can easily identify the lateral and the medial end, sternum and the shoulder part, the acromion. On the lateral part of the shaft, inferiorly, you will see some roughening. Let me show you that also. Can you see this part? This is all the lateral part. This was the lateral end. Okay, the acromion end. And you can see this is the I'm showing you the inferior surface. Can you see this inferior surface? This is all these tubercles over here. Actually, they articulate with the coracoid process of scapula. Try to understand what is happening over here. Now, over here, try to understand that behind we have the bone that is scapula. Okay. So in scapula, what actually happens is you have an anterior projection known as coracoid process, and then you have this big acromion process of scapula. So this is, imagine the acromion process, and this is, imagine the coracoid process. Now there's a clavicle which is coming over here, okay, and articulating like this. Okay, this is the lateral end, it forms the acromioclavicular joint. Okay. Now this clavicle is coming above the coracoid process. The clavicle is above the coracoid process. So what actually happens is that from coracoid to clavicle, we have these ligaments which attach the coracoid process to the clavicle. Okay, these are known as what? They are known as your coracoclavicular ligament. They are known as coracoclavicular ligament, and therefore they impart some tubercles over here, and those tubercles are known as conoid tubercle and trapezoid ridge. That names I will tell you, don't worry. But yeah, due to the coracoclavicular ligament, the inferior surface of clavicle, which surface? Because coracoid is below, na? Clavicle is coming over or above the coracoid process. So the inferior surface of clavicle has tubercles known as conoid tubercle, and trapezoid ridge. Don't worry with the names. Once you see their images and understand the conoid means they actually the ligament is cone shape, and trapezoid it resembles a trapezoid like we used to study in maths and physics. Simple as that. Tubercle is a small projection, right? And ridge is a linear projection sort of thing. Okay, so this is how this is seen on the inferior surface of the lateral third of the shaft. Okay, simultaneously over here, I don't know whether you can see it. Can you see a groove over here on the inferior surface again? Why inferior? You can see this tubercle. This tubercle is absent on the upper surface. Okay, this is the superior surface of the lateral third of the shaft of clavicle. Okay, now we are not seeing any tubercle over here. What we are seeing when we turn it on the inferior surface, then we see the tubercle. So this is the inferior surface. Now, if this is the whole clavicle, now look at the middle third of the clavicle inferiorly. Once you're looking at it in inferiorly, you might see, I'm bringing it closer. Now I think it is, now I think it's better. You might see a groove. That is a subclavian groove. Subclavian groove, because it is below the clavicle. A small muscle known as subclavius attaches over here. Okay. Now, forget everything. Even if from this last 15-20 minutes, you understood that, okay, I will identify clavicle, and I will also identify which side of clavicle it is, and 2-3 important landmarks. That is sufficient to for your beginning to clear your Viva exams for passing marks. This is must know thing. Okay. The rest we can see in the all the notes over here. Because if you are not able to answer these questions, which side it is, why it is of this side, then obviously the Viva won't go forward. Because if you are not sure that this is of right side, you are saying it is of left side, then obviously the Viva, the course of the Viva is a very, it takes on its, it goes with the flow. Okay, it's not like that there's an interview going on over, it goes with the flow. The whole flow actually is disturbed once the initial questions you are answering it wrong. That's the whole point. Okay. Okay, now let me show you the notes over here and see what are the important parts. How will you find the anatomical side of the clavicle? Clavicle transmits the weights. These are all notes thing over here. Okay. Oscillate. They have two prime centers. These are again whatever points I'm highlighting in the notes. These are actually must know points. You should know them, and they are frequently asked. So clavicle transmits the weight of the limb to the sternum. That is also important. Transmits the weight of the limb to the sternum. Now, every time there will be questions, let me point out the questions over here. As the first line goes, clavicle transmits the weight of limb to the sternum. Line is clear. And it is due to this reason. It is due to this reason that it is one of the most common bones, one of the most common bones in the upper limb to be fractured. Because suppose someone is falling on the ground, then they will obviously support their body with the hand, and the weight is transmitted from here. So this is also not a very big one, it's a thin one. Therefore, it gets fractured. The other reason of it being fractured is that it has this sinus curve over here. So obviously this part of the bone, the middle third of the bone, okay, is obviously at risk. Some curvaceous part. Also understand that one end is quadrangular and one end is flat. So when one end is quadrangular, sternal end or medial end, then this part of the bone is more rounded. And when this end is flat, then this part of the bone is more flatter comparatively. When one end of the bone is rounded, one end of the bone is flattened. Obviously, there has to be some transmission in between, and that occurs somewhere around the middle third of the bone. So somewhere around the middle third of the bone, or some books also will say the medial two-third and the lateral one-third junction. This is the area where this bone normally fractures. This is the area where this bone normally fractures. Try to understand this. Very important question asked. So as it transmits the weight, you can have few questions right from the first line. Two ends are the lateral medial. Fair enough. Ossification center, as I told, okay, it has two primary centers. That is also an exception. Normally, bones have one primary center only. But this one has two primary centers of ossification. Okay, secondary center is also there. Specificity of clavicle again. These are the things which are basically asked in your short answer theory exams. Yeah, you have to actually write the thing. So they have 5-6 points over here that you can actually read and write over here. Side determination. Lateral end is flat, acromial end, and middle end is large and quadrangular quadrilateral, as I am already repeated it multiple times. Shaft. Try to understand. Shaft is convex in medial two-third. Now see, it is convex in medial two-thirds anteriorly. This will be a complete statement, because if it is like this, we say it is convex in medial two-third. But convex from front or convex from back? It is convex from front. But if you say from the medial two-third, from the posterior aspect, then if you're looking at it from here, it becomes concave. Simple. One thing, you're seeing a gap in the palm over here, but if you're seeing from the back side, there's a projection from here. That's the main difference. What are the anatomical parts of clavicle? So any long bone will have a shaft. The shaft is divisible into lateral one-third and medial two-third. Okay. Then what else we have? Lateral one-third. We have, because it is more flatter, no? So it has on two borders, front and back. Because it is lateral part is more flatter. Okay. Inferior surface has an elevation, must know. Conoid, tubercle, and trapezoid disc. And this is one of the most important points by which you identify the side of the bone, clavicle over here. Because it is seen where? On the inferior surface. It is seen where? On the inferior surface. Okay. Medial two-third has 4 surfaces. Again, why medial side will have 4 surfaces? Because the medial end itself was quadrilateral or quadrangular. So it has 4 surfaces. Anterior surface is convex forward. Now this is better. Convex forwards or convex anteriorly. This is the way to go. Okay. Convex anteriorly also we can say. Posterior surface, smooth superior surface, and inferior surface, it has a groove over here, which I said already. Again, this point is very useful in identifying it. Okay, let's move forward. Attachments of clavicle. Now, attachments, mainly ligaments and the muscles. Think about what muscles will be attached onto the clavicle. Just move your upper limb and you obviously start to feel some muscles. Like this huge muscle over here, that deltoid muscle. It is coming from clavicle. Okay. Then you have this huge muscle in the front of the chest, the pectoralis major over here. Again, it is attached to clavicle. Actually, you can move your upper limb here and there, and you can actually feel the contraction of the muscles. Right? Then this is the muscle over here, the sternocleidomastoid. Once you turn your face to one side, this is sternocleidomastoid over here. Now, actually, cleido itself means clavicle. So this muscle over here is sternocleidomastoid. It is coming from mastoid process of the skull. It is attaching to sternum and clavicle. So again, sternocleidomastoid. Then you have trapezius muscle, this huge neck muscle over here, or the upper back muscle. Trapezius also attached to the clavicle. These are major muscles attached to clavicle. So lateral end is over here, acromioclavicular joint fine, middle end sternoclavicular joint fine. Now, if you are giving good answers, then they may ask you what type of joints they are. They are basically synovial joints, and different varieties. Fine. Let us see the muscle attachments. Don't worry about what is written. There's no much benefit from it, but yeah, look at the diagrams and try to understand the muscle attachments. So they're starting with the right clavicle bone over here, superior surface. Okay, right clavicle bone, superior surface. So you're looking at it from a superior aspect. Okay. And the same right clavicle bone from superior aspect, these are the bony features over here. These are the bony features over here. And here, you are seeing the muscle attachments. Here you are seeing the muscle attachments over here. Muscle attachments. So as I told you a few muscles over here, let me highlight them. Pectoralis major muscle. Okay. Then you have this trapezius muscle and deltoid. Trapezius deltoid will be more laterally. Trapezius deltoid will be more laterally, and pectoralis over here and sternocleidomastoid over here, they are mainly more medially. So understand in this image only that this is the medial side, that is the lateral side. As you can see from the ends also. Here, this is the same bone, sternal and medial end, and they are projecting it over here. What are the muscle attachments? These are major muscles. Inferiorly, as you can see, you have a subclavius muscle. So this was a subclavian groove over here. This two red arrows over here, they are denoting the subclavian groove. Then they have shown a few ligaments like thoracolclavicular and costoclavicular ligament. You see, so this bone is a must know, guys. This bone is a savior to, I can't tell you how many students, even I have passed, because they were not very good in other bones. But when I asked them, okay, pick up this bone, they're okay. This sort of we have read and we know this bone, so I had to give them passing marks because see, obviously it's not, the situations are not same for everyone. Some and also interests also differ. So we can't expect every student to know everything. So really few students who are not that good in the academic part and in the osteo part. So you have to give them chances. But even if you are not able to answer the clavicle bone, then things are not that good. There might be other reasons. Then we have to give them some less marks also at times. But yeah, so clavicle is a bone which should be known. Fracture of clavicle is then asked in the later part. Clinical importance, fracture of clavicle, one of the most common bones to be fractured. Oh, I'm again showing you if this for the last time, guys. Clavicle, have a look at it. Okay, from my right hand, this is the clavicle. The medial end, quadrilateral, quadrangular. The lateral end is more flatter. Compare it. Okay, right. Okay, this is the superior surface of the clavicle. It is more or less, we can say, it's smooth. But why also an anterior surface? Because you can palpate it, right? You can actually palpate it. Then, if you look at the lateral end, inferiorly, you are seeing this conoid tubercle and the trapezoid ridge over here. Okay, and in the middle of the shaft, you can see the subclavian groove. Again, middle and over here. Now we come to the next bone, that is the scapula. Now we have to come to the next one, that is the scapula over here. The scapula, few things again. It is again subcutaneous, you can feel it, but not particularly well. You can feel it on your own, but if you have a friend, okay, or your any friend or colleague or brother or sister, you want palpate, if you just stand behind the person, you can feel the whole scapula. A few things again over here that understand this bone is a triangular bone. It is, suppose this is a midline and you are seeing it from the posterior aspect. It is a triangular bone. It is a triangular bone. Okay. And it is a triangular. And once you start to palpate the scapula, you'll feel a spinous process coming out of it. I'm saying again, you have to start it to palpate it from the posterior aspect. It is behind the rib cage. You have a whole rib cage. You all know cylindrical rib cage. This scapula bone on both the sides is posterior laterally. If you talk of the rib cage, what does it mean? It means that suppose from the top you are seeing this rib cage. Suppose this is a rib cage you are seeing from top. This is the anterior side. This is posterior side. Then here you will have a scapula over here and a scapula over here. This is the whole point. It is lying behind the rib cage, posterolaterally. So once you palpate the scapula, you'll feel a projection coming out of it. This is known as the spinous process of the scapula. And the spinous process of the scapula, once you palpate it towards the shoulder, it continues as the acromion process of the scapula. Acromion, the same where the clavicle came and formed the joint over here. And once you look at the scapula from the anterior aspect, so anterior, there is one more projection over here known as coracoid process. Remember atavistic epiphysis in your general anatomy. Example on the one of the examples is this coracoid process of a scapula. Okay, here we also have a scapula over here. This is the scapula over here. Okay, so this is a triangle. You can see upper border, then a very thick lateral border. This is a thick lateral border over here. Okay, and a thin medial border. It's a triangular bone. It's a triangular bone. Okay, I'm giving it closer so you can easily focus it. But can you see a spinous process over here? The answer is no. So this side is facing the rib cage, because you can't have a spinous process coming out of it now at the rib cage, else you can't move your upper limb, because every time you move the upper limb, this spinous process will strike the ribs, and therefore it will get stuck. So you don't have a spinous process anteriorly. The spinous process is seen over here. Now, can you see the spinous process? This is whole spinous process. Okay, I'm bringing it a bit closer. Okay. Now I think, yeah. Now you can see it. This hole over here is the spinous process. And as you go laterally, it continues. The spinous process continues as what? This hole is the acromion process. This hole over here is the acromion process. And one process projecting anteriorly over here. This one, like a crow. This is your what? This is your coracoid process. Okay. So you have the coracoid process over here, and you have the acromion process over here. The spinous process is posteriorly. This part of the scapula is the posterior aspect or the dorsal aspect of a scapula. So this becomes the dorsal aspect of a scapula. This becomes what? It becomes the dorsal aspect of scapula. So spinous process is at the dorsal aspect. And the spinous process actually divides the scapula into supraspinous part over here, which I'm holding in my right hand. And this bigger one is the infraspinous part of the scapula. So you have a supraspinous part and you have an infraspinous part. And between you have the spine. So spine actually divides the scapula into supra and infraspinous. This is the rib cage side. This is the coracoid process. Now, one more thing which I wanted to show you over here. Can you see this pear-shaped structure over here? This cavity is the glenoid cavity. So which bone will articulate over here? It is the head of humerus. So head of humerus articulates over here and forms the ball and socket shoulder joint. So which side of scapula will it be? This is the anterior part, that is the posterior part. The glenoid will always face laterally. Okay, I have to keep it like this. But in an exam or viva voce, I have to keep it like this. Well, it's the right sided scapula. So if the examiner asks me which bone is it, I will say, sir, it is a scapula. Then he might wait for you to complete the answer that it is the scapula of right side. Or then the examiner's next question could be, if you have not told the side, the examiner will ask you, okay, which side of body it is it of the right or the left side? Then you will answer that it is of the right side. Then he might ask you, okay, why? Then you will say, the glenoid cavity over here, where the head of humerus will come, is facing laterally. You will say, okay, good. Then you'll say, sir, the spinous process which is coming out is on the dorsal aspect of the scapula. It's okay, fine. And it says the coracoid is moving anteriorly. It's okay. Then some examiners might also, and they are actually good questions, they might give you clavicle also. And they might ask you, okay, make a joint between clavicle and scapula. And if you're not aware, okay, where should I join it, at the spine process or the acromion or the coracoid, where should I join it? Then obviously the examiner finds out that your bases are not that good. But if your bases are good, you know that in clavicle, the lateral end, this forms a joint with the acromion process. So you will take the clavicle's acromion process and you will articulate it with the acromion of the scapula. Okay, by this, you have this acromioclavicular joint. Let me show you like this in all the angles. Clavicle has to be faced more anteriorly. Okay, they form an angle of about 60 degrees. Let me show you in different ways. Let's try to understand the acromion and the clavicle over here. Okay, and clavicle facing more anteriorly. This is also one of the most famous questions to articulate the different bones, not just clavicle, scapula, but other bones also. Okay, so identification of scapula, triangular bone, flat triangular bone. And this bone is basically there for the muscle attachments. Because upper limb has to make this ball and socket shoulder joint. No, a lot of movement has to be done. So a lot of movement will only be done if there is a good mobile joint and there are a lot of muscles which are assisting it. So therefore, the role of scapula comes into play. And then the examiner might also ask that, does the scapula has any direct connection with the vertebral column? Because the vertebrae are just adjacent to the medial border of scapula. This is the medial border of scapula. The vertebrae are lining over here. The thoracic vertebrae, T2, T3, T4, T5, T6, T7, all are lining just medial to the medial border of scapula. The answer is there's no joint over here. The scapula forms mainly two joints, one with the humerus ball and socket, and one with the clavicle at the acromioclavicular joint. Again, now there will be a lot of muscles over here. Again, I'm telling this that for the last time. That is actually a point to be called at the end. So understand the bone. So what is this bone doing? It is articulating with humerus, and whenever the humerus moves, this bone also moves. It is not static like this. Whenever the humerus moves, it is not only the humerus that is moving. Because when the humerus will move, it is evident. It is clearly seen. Okay, my humerus is moving, my upper limb is moving. But I would advise you that if you have not yet felt it, and keep your hand on the person who is standing in front of you, and you are standing behind that person. Keep your hand on that person's scapula and ask that person to move that side upper limb. You'll see all the movements, you'll feel the movements in the scapula also. Okay. So the scapula, anteriorly also we have muscle and we have the rib cage over here. It forms a very smooth and it moves around like this. There are some few things initially I want to tell you before discussing the notes of the scapula. But let's move to the notes part also. The scapula, the thin bone, plays in the posterolateral aspect of the thoracic cage discussed. It has two surfaces, three borders, three angles, three processes. Fine. Now, see, don't get intimidated by all these words. Okay, there's two surfaces. How to remember this? See, it is a triangular bone. It has two surfaces, one anteriorly, one back. Three borders. Obviously, triangle has three sides. Three angles. Triangle has three angles, so there are three angles. Three processes. What are three processes? Spinous process, acromion, and coracoid process. Fine. Right. Then ossification center, it has, see, it again will have only one primary, normally bones have one primary second center only, but there are multiple secondary centers. How will you find the side of scapula? Lateral side, as I showed, it has the glenoid angle or glenoid space over here. Again, I'm showing this spear shape. Okay, I hope it is clear now. This is the coracoid. Anteriorly, this is the acromion. And acromion continues as the spinous process. This is the glenoid. Dorsal, that is a posterior surface divided into supra and infraspinous. Clear? This is upper one is supra, lower one is infra. Costal surface has subscapular fossa. So costal surface, what is costal? Costal actually means rib. So the entire surface, the smooth surface, is the costal surface. It has a huge muscle over here known as subscapularis, and there forms a small fossa known as subscapular fossa. Explain the features. So features, costal surface or the subscapular. So this is the anterior part over here. Acts as a lever for the action of serratus anterior. Fine. The whole bone is acting as a lever only. Dorsal surface, they have a spinoglenoid notch. And what is spinoglenoid notch? These questions will only come when you identify the bone, the sides, and few basic questions. Then the point comes when the examiner might ask you, okay, where is spinoglenoid notch? Then again, you're starting to search. Don't worry. See, this is the glenoid. This is the glenoid cavity, right? Okay, let me bring it a bit closer. This is a glenoid cavity. Okay, this is spine. Can you see a notch in between? The spine is clear. There's some focus issue. I will rectify it later on, but yeah, this is the spine. Spine is clear. Glenoid is clear. Between you can you see this notch over here? That is a spinoglenoid notch. Border, superior border, lateral border, medial border. So lateral border is a thicker one. This is a thicker one. This is the lateral border. Below the glenoid, we have this lateral border. Middle border is thin. Angle, superior angle, inferior and lateral angle. Fine. So three angles are there in the image. Also, we can see over here that this is the superior angle over here. This is the superior angle over here. So it is on the middle aspect. The inferior angle is obviously very easy. Inferior angle is below, and the glenoid side is having the lateral angle. This is the known as the lateral angle or the glenoid angle. This much should be clear. Processes, again, there are three processes we have seen. Atavistic type of devices, again, the single line of questions might come. Do remember it. Okay. What are the muscles attached to scapula? Okay, what are the muscles attached to scapula? Let me show you the bone and quickly name, say around 10, 12 muscles over here. So first we'll start with the posterior surface of the scapula. Having the spinous process over here, the posterior surface of the scapula. Above the spine, supraspinatus muscle. Common sense. Below the spine, infraspinatus muscle. Two main muscles. The spinous process over here has two muscles, deltoid and trapezius. A deltoid, the lower part, and the trapezius over here. So 2 plus 2, 4 muscles. Supraspinatus, infraspinatus, deltoid, and trapezius. Okay, then we have the borders like medial border. Medial border on the posterior aspect will have your levator scapulae muscle, rhomboidus minor and major. 7 muscles. Lateral border will have teres minor, teres major. 9 muscles. Right? Inferior angle will have attachment of latissimus dorsi also. 10 muscles. Fair enough? Now this is the coracoid process. The anteriorly projecting over here. The tip of the coracoid process. The tip of the coracoid process has two muscle attachments. One is the short head of biceps, one is the coracobrachialis muscle. One is the short head of biceps, one is the coracobrachialis. Everything is there in the diagram, don't worry much about it. Okay, then you have this glenoid cavity, glenoid fossa. Above the glenoid fossa, we have a supraglenoid tubercle. We have a supraglenoid tubercle at the upper margin of the glenoid fossa. And we have an infraglenoid tubercle at the inferior margin of the glenoid fossa. At the supraglenoid, we have the long head of biceps, long head of biceps. And at the infraglenoid, we have the long head of triceps attachment. When we are saying, when I am saying biceps, triceps, it is for the upper limb only. So its complete name is biceps brachii and triceps brachii. Brachii is for the arm. So I think I told you like 12, 14 muscles, enough. That the same thing you can see over here. And yeah, anteriorly you have the, okay, two muscles are left. Subscapularis, which I already told you. But yeah, on the medial border, we said no muscles levator scapulae rhomboidus, but more importantly than these is the muscle on the medial border, but on the anterior aspect. That is serratus anterior. Very, very important muscle. Serratus anterior. It has serrations. Because why it has serrations? Because it is attached to 8 ribs. So it will have serrations. Okay, now the sides should be clear that which surface we are viewing. Can you see the spinous process over here? No, so it is the anterior surface, the ventral surface. Can you see the spinous process in this? Yes, so it is a dorsal surface or the posterior surface. Simple as that. So in the anterior surface or the costal surface, where I imagine it is attached to the ribs. With this huge muscle subscapularis must know. This blue color serratus anterior must know. So these are the must know two muscles over here. Infraglenoid, long head of triceps, supraglenoid, long head of biceps. You can see over here. These two are also asked. They are at the tip of coracoid process. They are at the tip of coracoid process. Omohyoid can also be asked. Pectoralis minor can also be asked. But yeah, these are important. Posteriorly or dorsally, if you see, you have the teres minor, major. Which border? Lateral border. Medial border, you have these three muscles. At the spinous process, below you have deltoid, above you have trapezius, and supra and infraspinatus. Now these are must know muscles. Inferior angle latissimus dorsi. In PG exams also, they are asked from 2020, last 3 to 4 years. 3 questions have come from this topic only. 2 questions which I easily remember was, one was in one exam, they gave the muscle of, they gave the scapula bone, and the scapula bone on this aspect, they showed a muscle like this. Okay, just that, no labeling, nothing. Fine. And then the question was that this marked muscle, they didn't name the bone nor the muscle. The question was that this marked muscle is supplied by which nerve? Simple as that. That was the question. For that, you have to identify the bone, then look at the muscle, then think about the muscle, then which muscle it is. It was actually your levator scapulae muscle. Right? And then you have to think about its nerve supply. Because the moment, even in your vivas, forget the MCQs, even in your vivas, once you have reached this a part of muscle attachment, then the examiner might ask you, okay, what is the nerve supply? How does it do act? What is the function of it? And questions like these. So nerve supply levator scapulae was over dorsal scapular nerve. The dorsal scapular nerve, that was the answer. Okay, later on, one more question was about the, I guess, the supraspinatus muscle. That question also has come. Questions have come directly as image based. So all these are muscles which are labeled over here, which we have sort of discussed. Yeah, winging of scapula as a clinical standpoint. But yeah, this you will study more basically once you study the gross part, that serratus anterior muscle, when this is paralyzed, then once you ask the patient to push against a wall, then the normal side there is not much projection of the medial border. It is fine, but in this side you can see there's more projection of the medial border of the scapula. Why? Because the muscle which was anteriorly attached on the medial border, serratus anterior, is not working now. So it is not binding the scapula to the ribcage like over here. So we have a medial projection of the medial border of the scapula on pushing against a wall. That is known as winging of scapula, or more correct word will be the medial winging of scapula. It is basically medial winging, because as you proceed further in your studies, you will see that there is a lateral winging also in some other paralysis, like paralysis of trapezius. We have a lateral winging also. That is a different thing. But yeah, winging of scapula is one of the most common questions that has been asked. Now let's identify ourselves with the last muscle, the humerus, the last bone, not muscle, but the humerus. Before moving to humerus, let me again show you this bone, the scapula over here. So again, you're seeing the spinous process over here and the glenoid cavity over here. This is which side scapula now? Is it of the right or left side? First of all, try to project the glenoid on the lateral side. And as it is of right side, you have to hold it in the right side. You have to hold it like this. This will be the correct way to hold the bone scapula. This is the right side of scapula, and the reasons are spinous process, glenoid, a bit of coracoid, borders. That's it. Okay. So now we come to the bone humerus. Humerus is a typical long bone. This is a simple as humerus. Not much, not many, very out of the way features are there in humerus. It is a simple long bone having two ends, upper and lower end. See, clavicle was very different. No, it was horizontal. The scapula is totally different. It's a flat triangular bone. It is a simple long bone we have. So upper and lower end, shaft in between. Upper end has this rounded surface. You can see the ball over here. Okay, it forms the ball and socket joint. It is the head of the humerus. It will fit, and this helps in moving our both upper limbs. Simple as that. And lower end is a bit expanded. This is the lower end. It articulates with the radius and ulna, mainly with ulna, and a bit with radius also. And it forms the elbow joint. And between you have the shaft over here. And a normal size shaft, not very huge, because we are bipedal people. We don't walk on our upper limb. Upper limb is basically, it is held loose and hanging from the body. And there's a slight swinging of the arm while you walk. When you walk, there's a slight swinging of the arm. That's it. We normally do all of our activities with this arm only. The upper limb has a totally different function. So the size of the bones is very different in upper and lower limb. Its counterpart in the lower limb is the femur. And if you look at the femur weight is around 3 to 4 times. I'm just roughly guessing it like this, but it's a huge bone. Its length is more, its girth is more, the femur bone, and its weight is also, but its weight is sort of light on. So it has two ends, upper and lower end, and a shaft. Upper end has this head over here, and below the head, this area is the neck of the humerus. In the neck, we say, okay, it's an anatomical neck, a surgical neck, and fine. Theory-wise, it is fine. Lower end, it is expanded from side to side. So we have, you can even feel it, no, the lower end over here. You're feeling this medial epicondyle. On the lateral side, you can feel the lateral epicondyle. This is the lower end of the humerus. This is the projection of the tip of the elbow. This is the olecranon process of ulna. This is the ulna over here. On the sides over here, you can actually feel the humerus, the lower 1/4 of the humerus you can feel, and as you come down, you will feel, okay, it is expanding sideways. Fine, so easy to identify, and 3-4 features are there that in the upper end of, first of all, side. So humerus you can identify. Side how to identify. See, we have a tubercle. Okay, let me bring it a bit closer. Yeah, we have a tubercle over here. It is projecting anteriorly. This is the lesser tubercle. Okay, the head of the humerus obviously is, will it face laterally or medially? Think about it. the head of the humerus, which is articulating with the glenoid fossa of the scapula. So head of the humerus will be facing medially or laterally. The head will be facing medially. So first of all, keep the head of the humerus on the medial aspect. You can't put it in the right hand with the head facing laterally. That is blunder, we can say. You have to hold the humerus having at least the head on the medial side. Once the examiner asks you which side it is, even if you are wrong, you say the head is facing medially. Examiner knows, okay, common sense is working. Okay, not gone totally blank. So head faces medially. Then this lesser tubercle, it faces anteriorly. The muscle attached over here is our subscapularis. Subscapularis muscle was on the anterior side of the scapula. Remember, on the scapula, subscapularis muscle was anteriorly. And in the humerus also, lesser tubercle gives attachment to subscapularis. You have a lesser tubercle over here, and on the upper lateral part, you have another tubercle. Can you see this area? This is the greater tubercle. There, here other muscles are attached. It goes behind also. This greater tubercle goes behind also. Other muscles of the scapula are attached over here. I'm not naming them. But between these two tubercles, can you see let me show you. Yeah, right over here. Can you see a groove going down? There, let me bring, yeah. This is lesser tubercle, that is greater. Can you see a groove going down? This is known as bicipital groove. Which groove? Bicipital groove. Why, sir? Why it's so complicated name? Or we can also call it as intertubercular groove. Because here you had a lesser tubercle, here is a greater tubercle. Between these two tubercles, you have a groove. So you can call it as intertubercular groove or bicipital. Now, why bicipital? Because here the biceps tendon will pass. The long head of biceps tendon will pass. And if I ask you, where was the long head of biceps tendon attached on the scapula? Answer in comment box because we have discussed it 5-10 minutes back only. Long head of biceps tendon in scapula. Where is it attached? Here I showed you. This is the bicipital groove. Then you come to the shaft. Shaft is normally smooth, but if you look at the shaft, this is the anterior part of the shaft. Now we are clear it is anterior. We have seen the head and the lesser tubercle. So this is the anterior part of the shaft. But if you turn it around in the posterior part of the shaft, you will actually feel a groove over here. Okay, this groove is for the radial nerve to pass. This is known as radial or the spiral groove over here. In the shaft also, they might ask you, because deltoid is a huge muscle, guys. Once you abduct your shoulder, be you are muscular or not, less or more, that doesn't make any difference. But you will feel this muscle over here. This muscle, this is the deltoid muscle. And this muscle attached onto the middle of the humerus on the lateral part of shaft. This deltoid muscle is attached. You can actually feel it and see it on your own body. It is attached on the somewhere in the middle of the humerus laterally. So if you look at the humerus again over here, then this is the anterior of the humerus. So laterally, this is the lateral part of the humerus. Somewhere in the middle, can you see this groove over here? That is known as deltoid tubercle. So deltoid muscle actually pulls on the bone. So with the time, it will make a groove on it, known as deltoid tuberosity or deltoid tubercle. That is one way. So in the shaft, do remember that posteriorly we have a spiral groove. Posteriorly we have a spiral groove, and on the lateral surface, somewhere in the middle, we will have the deltoid tubercle. And as you come down, guys, this is expanded. Okay, we have a capitulum and the trochlee also. Capitulum on the lateral side, trochlee on the middle side. Fine. But once you turn this bone, once you see the posterior aspect of the bone, this is again very important point in identifying the side of the humerus. 2-3 points we already discussed. Head facing medially, lesser tubercle, fine. Okay, deltoid tubercle laterally, fine. But very easily seen from far away. Not even, you don't need to even touch it. Is as you see the lower end. Now this is the right humerus I'm holding in my right hand. You see the lower end. Okay. Here you are seeing the capitulum and the trochlea where the radius and ulna will come and attach. But as I turn this bone around, okay, I'm keeping this. You can see the big hole over here. A big hole. That is the olecranon fossa. This is the posterior side. This is the anterior side. Anteriorly, you are seeing all this bone structure. I am showing you guys the lower end of humerus. But as I turn this bone around, you see a whole fossa. You see a whole fossa over here. That is the olecranon fossa. And I showed you over here, no, that this part, this is the olecranon process. So actually this process of ulna actually fits inside this fossa. Where will you find the fossa? Posteriorly. So now before showing you even one line of notes, I gave you so many points. So in humerus, do remember few points. Like look at you will identify the bone, which I am sure you will. Side determination is very, very important. For side determination, look at the head of the humerus facing it. Head should be facing medially. Then think of the lesser and greater tubercles. Try to see them, lesser and greater tubercles. Lesser tubercle, they're more anteriorly. Then don't forget about the groove, the intertubercular groove. Also look at the radial groove posteriorly. Also look at the deltoid tuberosity on the middle of the shaft. Don't ever miss out on the olecranon fossa. This is very big fossa, which is easily relevant. Where it is seen? It is seen on the posterior aspect. This is seen on the posterior aspect. This is seen on the middle of the shaft laterally. Middle of the shaft laterally. Radial groove is present posteriorly. This groove is the intertubercular groove. Keeping in mind these 4-5 things, easily identify the humerus. And let's see now what are there in the notes over here for you to for better understanding. Obviously, it is the longest bone in the upper limb. It is the upper rounded end, a lower flattened end, and a shaft. Typical long bone. Okay, a few simple labelings over here. How are you going to find the side of humerus? I can see why I like these notes so much, because it gives you a very clear mindset that okay, uh, what topic you are actually reading about. So upper end is rounded to form the head, lower end is expanded. You have seen head is directed medially is more important. Lesser tubercle projects from the upper end, where anteriorly or posteriorly, guys? Anteriorly, okay. Laterally, you have this laterally by the intertubercle surface of axial. Other points which I have already told you, we can add the olecranon fossa, do add lying posteriorly. Okay. Features of humerus upper end head. Few features are there. How the direction, how does it articulate, that we already have seen. We've seen the scapula. And the line separating the head from the rest is the anatomical neck. So guys, what actually happens is that you have this head of the humerus over here. And suppose that I'm trying to make this whole humerus. Okay. What actually happens is this part of the neck is known as anatomical neck. It is below the head, so we call it neck. But over here, when the whole upper end is separated from the shaft, this part is known as the surgical neck. Surgical neck of humerus. So you'll see it more. Lesser tubercle elevation on the anterior aspect. Don't forget this. Greater tubercle goes laterally. Intertubercular sulcus we have seen with the different muscles attached to it. And few points over here, humerus bone anteriorly and posteriorly. Okay, posteriorly what we will have mainly radial groove and olecranon fossa. Don't miss out on these important points. Look at the anatomical neck and surgical neck locations. Anteriorly, don't forget the lesser tubercle, the deltoid tuberosity, and capitulum trochlear also. Simple names you should know. Whatever I'm highlighting, guys, this is actually must know. No, you can't miss them. Shaft is rounded in the upper half and triangular in the lower half, sort of similar as clavicle if we can tilt it. Borders over here, anterior border, lateral border, middle border, fine. You can go with it. Just read them once or twice. Spatial points over here. We have a deltoid tuberosity. Don't forget it. Anterior middle surface, lower and fine. Capitulum trochlea. Don't forget it is articulating with which bones. As the lower end of the humerus is forming which joint? Elbow joint. For elbow joint, you have bones humerus, radius, and ulna. Humerus, radius, and ulna. Radius and ulna are the two bones of the forearm. In elbow, it is mainly the ulna which is participating compared to radius. So if someone asks you radius and ulna, main bone in the elbow is ulna. So therefore, you are seeing this huge olecranon process. And the part of the humerus that articulates with ulna is this trochlea over here. So articulates with ulna over here. So do remember these two names, trochlea and ulna. Capitulum, trochlea and capitulum. Capitulum articulates with the radius. Capitulum will be more laterally or medially. It is facing lying on the lateral side, and trochlea lying on the medial side. Then you have the two epicondyles. Epicondyles are there, the lower projections. No, when there was a shaft and it came down, you have the projections. So you can actually feel both the epicondyles. They are subcutaneous. This is medial epicondyle over here. I'm feeling this. This medial epicondyle. That over here is my lateral epicondyle. You can feel it on your own elbow region, right? Muscle attached to humerus, again, a lot of muscle attached to humerus. And see, don't go with all these names first of all, what is written. Look at the image. Look at the image and try to correlate, okay, this muscle is coming from there, because most of the muscles that you will see in here, humerus, basically the upper part of the humerus, this part, most of the muscles that you will see are actually coming from clavicle and scapula. So therefore, at the upper half of humerus, now what I'm teaching you over here is not the bookish part, but developing a concept. So you might find, okay, sir, what you're saying, but think about it. It helps you in learning. The upper half of the humerus will normally have insertion of muscles, because the muscles over here are normally coming from where? From either from clavicle or from scapula. Let us see some example. Deltoid is attached to upper part. Was coming from where? Coming from clavicle and scapula. Then here supraspinatus coming from scapula. Subscapularis, pectoralis major, latissimus dorsi, teres major, all are coming from the scapula part or clavicle. So they have insertions. While as you go down in the lower part of the humerus, you will see that from here the muscles will go obviously down. Down where? Either in the forearm or in the hand region. So here you normally see the origin of muscles. For example, brachialis, brachioradialis, pronator teres, extensor carpi radialis, flexor, extensor origin. All these are going down. So there you have mainly, here you have the origin of muscles. What is origin and insertion again? In your basic general anatomy, whenever the muscle contracts, suppose I'm moving my upper limb like this, whenever my muscles are contracting, one end of the muscle moves more, and that end of the muscle which moves more is normally the insertion part of the muscle. The origin part, it also moves but less. This is again having very questionable parts over here, because movement depends on which part you are keeping stabilized. For example, let me give you an example that why this origin and insertion uh, uh, concept is challenged very frequently. The reason is, let me give you an example. You are walking on the road. Now your foot is stabilized. Once you're walking, or you're standing, forget about walking, you're standing. Once you're standing, your leg muscles or lower limb muscles are contracting, but your foot is stabilized on the surface. Clear? Second scenario, you're sitting on a chair and your foot is hanging. It is not placed on the surface. Suppose the chair is at a higher level. You are simply sitting on chair. And then when you move your lower limb, like straightening your knee, even then the muscles are contracting. But at this time, the lower or the foot is not stabilized. So the origin and insertion of the muscle changes. So standing, and once you're sitting on a chair or at a at a little bit higher location, so that your foot is not stabilized on the surface, on the ground. And both cases, when the muscles contract, their origin and insertion, they are interchangeable. I just gave you one simple example. Okay, think about it. Okay, food for thought, if we may say so. Right. So these are three important bones. I guess we have covered up three important bones. I urge all of you guys to revise it. These are must-know bones. If you this solves actually two purposes: for you to pass the Viva VOC exams in the first year. For orthopedics also, they will be asked, because they are one of the most common bones to be fractured. And obviously for your PG exams, as I told you, I gave you a few questions, or discussed few questions over here, which are coming in PG exam, and they are covered up from here, right? So that's all from my side, guys. I hope you enjoyed, and any queries, let me know. And that's all. Bye bye. Good night. Take care.